So let's continue. Um, we talked about the crash injury of dorsal roots, which makes sense. We've talked about anatomic bladder. Let's continue talking a bit about problems with the micturition reflex. So, yeah.
All right, so you got the atonic bladder concept down. Want me to tie it back to how this might worsen in sickle cell disease? Or maybe explore another urinary tract topic, like how sickle cell affects the kidneys directly? What's the vibe?
Well, how can
No
stroke
rush.
how can stroke injury and Alzheimer's disease and problems affecting the cerebral cortex of the hypothalamus, how can they lead to urinary incontinence?
Stroke, Alzheimer's disease, or other issues affecting the cerebral cortex or hypothalamus can cause urinary incontinence by disrupting the brain's control over the micturition reflex. A stroke or Alzheimer's can damage the cortex, which normally sends voluntary signals via the pudendal nerve to control the external urethral sphincter and coordinates with the hypothalamus to inhibit or facilitate peeing. Without this control, the bladder may contract uncontrollably, urge incontinence, or overflow due to lack of sensation, while hypothalamus damage can mess up the autonomic signals, pelvic and hypogastric nerves that regulate detrusor and sphincter function, leading to similar issues. In sickle cell disease, where strokes are a risk due to vasoocclusion, this can compound urinary tract problems like infections. Want me to break down one condition's impact or link it to sickle cell kidney effects?
It's good. And so these bladder sphincter muscles, they also can lose their tone after pregnancy. Talk to us a bit about that.
Yep, you're right. After pregnancy, the bladder sphincter muscles, particularly the external urethral sphincter and pelvic floor muscles, can lose tone due to stretching and pressure from the growing uterus, prolonged labor, or vaginal delivery, which weaken the pudendal nerve's control and supporting tissues. This reduced tone can lead to stress urinary incontinence, where coughing or sneezing causes leaks, and in sickle cell disease, this could worsen infection risks if bladder emptying is already compromised by vasoocclusion. Want me to dive into how pregnancy affects these muscles more, or connect it to sickle cell complications?
I wanna ask you about urinary retention. So how that can it develop if in males if enlarged prostate gland compresses the urethra and restricts urine flow?
Urinary retention in males can develop when an enlarged prostate gland, often due to benign prostatic hyperplasia or prostate disease, compresses the urethra, narrowing the passage and obstructing urine flow from the bladder, making it hard to empty completely. This can lead to a buildup of urine, increasing the risk of infections or kidney strain, which is especially problematic in sickle cell disease, where vasoocclusion already stresses the urinary tract. Want me to explain how this impacts the kidneys further, or dive into another aspect?
I see.
Cool.
What
So you're
about
tracking with
urinary? Okay. So wait. So just a second. Sorry.
no stress.
Urinary retention develops from a. How does an enlarged prostate gland? What does it have to do with the urinary retention?
All right, no worries. Let's clarify how an enlarged prostate causes urinary retention, keeping it simple. An enlarged prostate gland, common in older men due to conditions like benign prostatic hyperplasia, presses on the urethra, the tube that carries urine out of the bladder, squeezing it and blocking the flow. So the bladder can't empty properly, leading to urinary retention. This buildup of urine can cause discomfort or infections. And in sickle cell disease, It worsens the risk of urinary tract complications. ¿Quieres que explique más sobre cómo afecta los riñones?
Excuse me, sir. Why is speaking English, please?
My bad. Let's stick to English. An enlarged prostate causes urinary retention by compressing the urethra, blocking urine flow from the bladder, so it can't empty fully, leading to urine buildup.
I see. And how can a prostate become enlarged?
A prostate can become enlarged mainly due to benign prostatic hyperplasia, BPH, a common condition in older men where hormonal changes cause prostate cells to grow excessively, or due to prostate cancer, infections, or inflammation, prostatitis, all of which swell the gland and compress the urethra. This obstruction can worsen urinary retention, and in sickle cell disease, it could amplify risks like urinary infections due to vasoocclusion. Want me to dive into one cause or its impact on the urinary tract?
Well, I want to ask again about incontinence, if you can remind me what it means. And I want to talk about the main types. So, loss of sensory nerves due to injury, involuntary bladder contractions due to injury, and heightened urge incontinence from a sensitive bladder.
All right, let's revisit incontinence and cover its main types, including the ones you mentioned, keeping it clear. Incontinence is the inability to control urination, leading to unintentional urine leakage. The main types tied to your points are 1. Loss of sensory nerves due to injury, sensory neurogenic incontinence. If sensory nerves, like those in the pelvic nerve, are damaged, e.g. from spinal injury or diabetes, you can't feel when the bladder is full, leading to overflow incontinence, where the bladder leaks without warning because it overfills without triggering the micturition reflex. 2. Involuntary bladder contractions due to injury, detrusor overactivity or urge incontinence. Injury to the spinal cord or brain, e.g. stroke or paraplegia, can disrupt inhibitory signals, causing the detrusor muscle to contract unexpectedly, leading to sudden, uncontrollable urges to pee and leakage, even if the bladder isn't full. 3. Heightened urgency continence from a sensitive bladder, overactive bladder. This isn't a true type of incontinence, but a condition where a hypersensitive bladder, often from irritation, infection, or neurological issues, causes frequent, urgent needs to urinate, sometimes leading to urge incontinence if you can't make it to the bathroom in time. In sickle cell disease, vasoocclusion or nerve damage from strokes can worsen these by weakening bladder control or increasing infection risk, impacting the kidneys. Want me to clarify one type or connect it to sickle cell effects?
I want to ask about the atonic bladder again, how it's connected to this.
An atonic bladder, where the detrusor muscle can't contract properly due to nerve damage, like from spinal injury or pelvic nerve disruption, connects to incontinence because it causes overflow incontinence. A type where the bladder overfills and leaks without you feeling the urge to pee. This happens because damaged sensory or motor nerves fail to signal fullness or trigger detrusor contraction, leading to urinary retention and eventual leakage, which can worsen infection risks in sickle cell disease. Want me to explain how this differs from other incontinence types or its impact in sickle cell?
How much creatine should I be taking?
Creatine supplementation depends on your goals, body weight, and activity level, but for general use, like muscle building or performance, the standard protocol is a loading phase of 20 grams per day, split into 4 doses of 5 grams for 5 to 7 days, followed by a maintenance dose of 3 to 5 grams daily. Always consult a doctor first, especially with sickle cell disease, as creatine can stress the kidney.
So, wait, what about 3 to 5 grams a day? What about 10 grams a day as maintenance?
Taking 10 grams of creatine daily as a maintenance dose is generally safe for healthy adults and can be effective for those with higher muscle mass or intense training, providing slightly more muscle and performance benefits than the standard 3 to 5 grams. But there's little evidence that more than 5 grams is necessary for most people. Without sickle cell disease, the risk is low, but you should still check with a doctor to ensure it suits your health.
Can I
as
ask?
high doses
Wait. So let's say I'm a male. I'm 25 or 22, and yeah. Let's say let's say
All right. Let's say you're at 22.
I'm athletic, and let's say I'm 85 kilos.
All right. As a 25-year-old athletic male weighing 85 kilos, a creatine maintenance dose of 5 to 10 grams daily is reasonable after a loading phase of 20 grams daily, split into 4 doses for 5 to 7 days, with 5 grams often enough for muscle and performance benefits, but 10 grams could maximize saturation for intense training. Consult a doctor to confirm it's safe for your health, as high doses might affect kidneys long-term, even without sickle cell disease.
Okay.
Want me to...
Let's talk a bit about. Well, can you tell us the research on creatine, dude? What does the research say? Does it say that after 5 you don't get any benefits? Does it say if you're heavier and you have more muscle, get more than 5?
Research on creatine, based on decades of studies, shows it's effective for boosting muscle strength, power, and recovery, particularly in high-intensity activities, with most benefits seen at a maintenance dose of 3 to 5 grams daily, after a 20-gram loading phase for 5 to 7 days. For heavier individuals or those with more muscle mass, like an 85-kilo athletic male, some studies suggest 5 to 10 grams daily may better maintain muscle creatine stores. But beyond 5 grams, extra benefits are minimal unless you're pushing extreme training volumes, and no clear evidence supports needing more than 10 grams daily for anyone. Want me to dig into specific studies or creatine's effects on kidneys for peace of mind?
Tell me about the kidneys, yeah.
Research shows creatine supplementation at standard doses, 3 to 5 grams daily, or up to 10 grams for heavier athletes, is generally safe for healthy kidneys in young, athletic people, with no consistent evidence of kidney damage in studies, though it can slightly raise creatinine levels, a marker often monitored. However, if you have pre-existing kidney issues or take high doses long-term, there's a potential risk of strain, so consulting a doctor is key, especially to ensure no impact on urinary tract function. Want me to dive into specific studies or tie this to sickle cell kidney concerns?
So should I cycle off supplements like multivitamins and stuff like that, and iron?
Cycling off supplements like multivitamins and iron isn't usually necessary for healthy people, but it depends on your diet, health, and needs. Multivitamins can be taken daily if you're deficient in nutrients, while iron should only be supplemented if you have confirmed low iron levels, as excess iron can harm organs like the kidneys or liver. For an athletic 85-kilo male, unless you have specific deficiencies or conditions, like anemia unrelated to sickle cell, you might not need to cycle off, but should consult a doctor to avoid overloading, especially with iron.
So, let's talk a bit about the drugs used in urinary incontinence. So, we've talked about this detrusor muscle. We've talked about incontinence in general. So, yeah, what are the drugs used in this situation? And how also does acetylcholine ACH play a role in this game with the pelvic nerve and everything?
All right, let's dive into drugs for urinary incontinence and how acetylcholine, ACH, plays a role, tying it to the detrusor muscle and pelvic nerve. Urinary incontinence, like urge or stress incontinence, is often treated with drugs targeting the bladder or sphincters. 1. Anticholinergics, e.g. oxybutynin, tolterodine. These block acetylcholine's action at muscarinic receptors in the detrusor muscle, reducing unwanted contractions to treat urge incontinence, overactive bladder, calming the bladder to prevent sudden leaks. 2. Beta-3 agonists, e.g., mirabegron. These relax the detrusor muscle by stimulating beta-3 receptors, increasing bladder capacity for urge incontinence without directly involving ACH. 3. Alpha agonists, e.g., pseudoephedrine. Used for stress incontinence, these tighten the internal urethral sphincter to prevent leaks during pressure,
How
like
come
coughing.
acetylcholine is the one that helps? Sorry guys, just a second. How come acetylcholine is the one that helps with micturition, with peeing?
Acetylcholine helps with micturition because it's the main neurotransmitter released by the pelvic nerve, parasympathetic, S2, S4, which binds to muscarinic receptors on the detrusor muscle, triggering it to contract and push urine out while also relaxing the internal urethral sphincter. This setup ensures the bladder empties efficiently when the micturition reflex kicks in.
But why
drugs like
acetylcholine? Why acetylcholine though, dude? This is what I don't understand, because acetylcholine usually is the relaxing person. It's not the like let's push and contract and everything, no?
I get the confusion. Acetylcholine can seem tricky since it's involved in different roles. In the bladder, acetylcholine isn't the relaxing guy. It's the action trigger for micturition because the pelvic nerve, parasympathetic, releases acetylcholine to bind muscarinic receptors on the detrusor muscle, causing it to contract and squeeze urine out, while also relaxing the internal urethral sphincter. Acetylcholine was evolutionarily selected here because the parasympathetic system, which uses acetylcholine, is wired for rest and digest functions, including emptying the bladder efficiently, unlike its role in skeletal muscle, where it causes contraction via nicotinic receptors, or other systems where it might relax.
Wait, what do you mean?
Wait.
What do you mean that in nicotinic receptors causes contraction? I thought it causes relaxation.
My bad for any confusion. Let's clear up acetylcholine, and nicotinic receptors. Acetylcholine binding to nicotinic receptors, like in skeletal muscles at the neuromuscular junction, causes muscle contraction, not relaxation, by triggering sodium influx that leads to muscle fiber activation. Think lifting your arm. In the bladder, acetylcholine works differently. It binds muscarinic receptors on the detrusor, smooth muscle.
Fucking hell, dude. You used to be interrupted this year. Now I have to talk over you. Anyway, so wait, acetylcholine. So it's in the parasympathetic. I thought parasympathetic means that we relax our muscles.
Totally get the mix-up. The parasympathetic
Can you
system,
talk a bit slower?
which uses acetylcholine.
Hey. Can you talk a bit slower?
No problem. I'll slow it down. The parasympathetic system, using acetylcholine, isn't always about relaxing muscles. In the bladder, it releases ACH through the pelvic nerve to make the detrusor muscle contract, not relax, which pushes urine out during peeing. Parasympathetic does relax some things, like in digestion, but for micturition, it's the contraction trigger. Clear now, or want me to go over it another way?
That makes sense. So that's why we would take anticholinergics, for instance. Can we talk a bit about oxybutynin, and then let's talk a bit about tricyclic antidepressants like imipramine and how we could use those too?
All right, let's dive into oxybutynin and tricyclic antidepressants like imipramine for urinary incontinence. Keeping it clear and slow. Oxybutynin is an anticholinergic drug that blocks acetylcholine from binding to muscarinic receptors on the detrusor muscle, preventing unwanted contractions and calming an overactive bladder, which helps treat urge incontinence by reducing sudden urges to pee. Imipramine, a tricyclic antidepressant, works differently. It has anticholinergic effects to relax the detrusor and also boosts sympathetic activity to tighten the internal urethral sphincter, making it useful for both urge and stress incontinence, especially in cases like nighttime wetting or mixed incontinence. In sickle cell disease, these drugs could help manage incontinence from nerve or muscle damage, but caution is needed due to potential side effects like dry mouth or constipation. Want me to detail their side effects or how they specifically help in sickle cell?
I want to understand how the names relate to their functions, and I don't understand tricyclic antidepressants very good, to be honest.
All right, let's break down oxybutynin and tricyclic antidepressants like imipramine, focusing on how their names relate to their functions and clarifying tricyclics, keeping it slow and simple. Oxybutynin. The name doesn't directly scream its function, but it's an anticholinergic drug, meaning it blocks acetylcholine, ACH. The oxy part vaguely hints at its chemical structure, but its job is to stop ACH from making the detrusor muscle contract, calming the bladder to prevent urge incontinence, sudden pee urges. It's called anticholinergic because it opposes ACH's action at muscarinic receptors, reducing bladder spasms. Tricyclic antidepressants, like imipramine. The name tricyclic comes from their chemical structure, which has 3 rings of atoms, but that's just chemistry talk. They're called antidepressants because they were first used to treat depression by boosting brain chemicals like serotonin and norepinephrine. For incontinence, imipramine's anticholinergic side effect relaxes the detrusor, like oxybutynin, blocking ACH to curb urge incontinence, and it also stimulates sympathetic nerves, mimicking the hypogastric nerve to tighten the internal urethral sphincter, helping stress.
Okay. Wow, we've got so many, don't we? Okay. And in acute urinary retention, we might do catheterization. What is this?
All right, let's keep it simple and slow for acute urinary retention and catheterization. Acute urinary retention is when you can't pee at all, causing bladder buildup, often due to something like an enlarged prostate blocking the urethra. Catheterization is a procedure where a thin, flexible tube, catheter, is inserted through the urethra into the bladder to drain urine, relieving the retention and preventing complications like infections or kidney strain, which can be critical in sickle cell disease, where urinary issues are already a risk. Want me to explain types of catheters or how this helps in sickle cell?
I want to ask about the hypogastric nerve. So the hypogastric nerve has to do with noradrenaline. So maybe we will use a drug to inhibit this, and I don't understand. And the pelvic nerve has acetylcholine.
All right, let's clarify the hypogastric nerve. It's linked to noradrenaline, the pelvic nerve's use of acetylcholine, and how drugs might target the hypogastric nerve, keeping it slow and clear. The hypogastric nerve, sympathetic, T10L2, releases noradrenaline to relax the detrusor muscle and tighten the internal urethral sphincter, helping store urine and prevent leaks during bladder filling. The pelvic nerve, parasympathetic, S2S4, releases acetylcholine to contract the detrusor and relax the internal sphincter, triggering micturition, peeing. For urinary issues like urge incontinence, you might use a drug to inhibit the hypogastric nerve's noradrenaline effect indirectly, such as alpha blockers, e.g., tamsulosin, which block noradrenaline's action on the internal sphincter, relaxing it to ease urine flow in cases like prostate-related retention. However, for incontinence, drugs typically target acetylcholine, e.g., oxybutynin, to calm the pelvic nerve's detrusor contractions, rather than the hypogastric nerve. In sickle cell disease, these drugs could help manage retention or incontinence from nerve or blood flow issues. Want me to dive into alpha blockers or clarify how these nerves balance?
Well, I kind of want to ask you about alpha-1, alpha adrenoreceptors. How are they in the mix? How do they relate to everything else like noradrenaline? And so does noradrenaline in the hypogastric nerve make us pee more or retain versus the pelvic acetylcholine?
All right, let's break down alpha-1 adrenergic receptors, their role with noradrenaline, and how they tie into the hypogastric and pelvic nerves for urination, keeping it slow and clear. Alpha-1 adrenergic receptors are proteins in the internal urethral sphincter and bladder neck that noradrenaline, released by the hypogastric nerve, sympathetic T10L2, binds to, causing the sphincter to tighten and the detrusor muscle to relax, which promotes urine retention by keeping the bladder closed and preventing leaks during filling. In contrast, acetylcholine from the pelvic nerve, parasympathetic S2S4, binds to muscarinic receptors, contracting the detrusor and relaxing the internal sphincter to make you pee during micturition. So noradrenaline via the hypogastric nerve helps you hold urine, while acetylcholine via the pelvic nerve triggers peeing. Alpha blockers, e.g., tamsulosin, can inhibit alpha-1 receptors, reducing noradrenaline's tightening effect on the sphincter, easing urine flow in conditions like prostate-related retention. In sickle cell disease, these dynamics matter since vaso-occlusion can weaken these controls, increasing incontinence or retention risks. Want me to focus on alpha blockers or how this balance affects sickle cell urinary issues?
If you can summarize in a sentence or two what you said, basically.
Noradrenaline from the hypogastric nerve binds alpha-1 adrenergic receptors to tighten the sphincter and relax the detrusor, promoting urine retention, while acetylcholine from the pelvic nerve contracts the detrusor and relaxes the sphincter to trigger peeing. Alpha blockers can loosen the sphincter by blocking noradrenaline, helping with retention, which is key in sickle cell where nerve or blood flow issues can disrupt this balance.
So acetylcholine will contract the sphincter to make retention. To make contraction.
I think there's a bit of a mix-up here, so let me clarify super clearly and slowly. Acetylcholine, released by the pelvic nerve, parasympathetic S2S4, does not contract the sphincter. Instead, it contracts the detrusor muscle to push urine out and relaxes the internal urethral sphincter to allow urine to flow into the urethra during micturition, peeing. This is the opposite of retention. It promotes urination. For retention, the hypogastric nerve, sympathetic T10L2, releases noradrenaline, which binds alpha-1 adrenergic receptors to tighten the internal sphincter and relax the detrusor, keeping urine in the bladder. So,
Okay.
AC.
So acetylcholine will relax the detrusor, contract the detrusor muscle, whereas noradrenaline will contract the sphincter. Can you summarize in a sentence the difference?
Acetylcholine from the pelvic nerve contracts the detrusor muscle and relaxes the internal sphincter to promote urination, while noradrenaline from the hypogastric nerve contracts the internal sphincter and relaxes the detrusor to promote urine retention. Want me to clarify further or move to another topic?
No, that makes sense. Can I ask about prazosin too?
All right, let's talk about prazosin. Prazosin is an alpha-1 adrenergic receptor blocker that inhibits noradrenaline's action on alpha-1 receptors in the internal urethral sphincter and bladder neck, causing the sphincter to relax and easing urine flow, which is useful for urinary retention caused by conditions like an enlarged prostate. By counteracting the hypogastric nerve's retention-promoting effect, it helps reduce bladder outlet obstruction, but it's less commonly used for incontinence and needs caution in sickle cell disease to avoid worsening blood flow issues. Want me to compare prazosin to other drugs like tamsulosin or tie it to sickle cell urinary effects?
So this blocks alpha adrenergic. So it means noradrenaline will not bind, and if it's not binding, it means that we will have contraction and relaxation of sphincter, and we have relaxation of detrusor and contraction of sphincter. I just want to ask, what's the function of the detrusor and the sphincter? So it seems like relaxing the sphincter promotes peeing, which makes sense. Okay. Whereas, so the detrusor comes before the sphincter.
All right, let's clarify prazosin's effects, the roles of the detrusor and sphincter, and their order in the urinary tract, keeping it simple and addressing your points. You're right that prazosin, an alpha-1 adrenergic receptor blocker, stops noradrenaline from the hypogastric nerve from binding to alpha-1 receptors, but let's correct the outcome. This causes the internal urethral sphincter to relax, not contract, and has little direct effect on the detrusor, which is mainly controlled by acetylcholine, pelvic nerve for contraction, or noradrenaline for relaxation. By relaxing the sphincter, prazosin promotes urine flow, helping conditions like urinary retention from prostate compression.
Okay.
Not by
Can I ask about the parasympathomimetics and bethanesol?
All right, let's dive into parasympathomimetics and bethanicol, keeping it concise and clear. Parasympathomimetics are drugs that mimic or enhance the action of acetylcholine, the neurotransmitter of the parasympathetic nervous system, like the pelvic nerve, S2, S4, in the bladder. Bethanicol, a parasympathomimetic, stimulates muscarinic receptors on the detrusor muscle, causing it to contract and promote urination, while also relaxing the internal urethral sphincter, making it useful for treating urinary retention, e.g., after surgery or in neurogenic bladder, where the bladder can't empty properly. In sickle cell disease, bethanicol could help if retention occurs due to nerve or muscle issues, but it must be used cautiously to avoid overstressing the urinary tract. Want me to compare bethanicol to other drugs or explain its risks in sickle cell?
I want you to explain to me. I want you to explain to me again in a sentence or two what you just said.
Bethanicol, a parasympathomimetic drug, mimics acetylcholine to stimulate the detrusor muscle to contract and relax the internal urethral sphincter, helping treat urinary retention by promoting urination. It can aid in sickle cell disease if retention occurs, but requires careful use to avoid urinary tract strain. Want more on its use or risks?
I don't get its job, to be honest.
No worries. Let's make bethanicol's job super clear. Bethanicol acts like acetylcholine to make the bladder's detrusor muscle squeeze, pushing urine out, and relaxes the internal sphincter to let urine flow, helping when you can't pee due to a weak bladder, like in urinary retention. Think of it as a Kickstarter for peeing. Clear now, or want another angle?
I don't get it.
All right, let's try a simpler take. Bethanicol is a drug that tells the bladder muscle, detrusor, to tighten and the inner sphincter to loosen, like pressing a button to make you pee when your bladder won't empty on its own, such as in
Okay, I
urinary
see.
retention.
Alright guys, thank you so much for watching, and can we do a small quiz of all the drugs we mentioned actually before we close?
Awesome. Love the wrap-up energy. Let's do a quick quiz on the urinary incontinence and retention drugs we talked about. Oxybutynin, imipramine, prazosin, and bethanicol. Here are 4 short questions to test your grasp. 1. What does oxybutynin do to help with urge incontinence? A. Tightens the sphincter. B.
No,
blocks it.
I prefer it to be like I have to answer in 1 or 2 words and you make a question.
Perfect. Let's do a quick fire quiz where you answer in 1 or 2 words. Here we go. 1. What muscle does oxybutynin relax?
The sphincter.
Close, but oxybutynin relaxes the detrusor muscle. Next question. 2. What nerve's action does prazosin block?
Hypogastric.
Spot on. Prazosin blocks the hypogastric nerve's action. All right, question 3. What does botanicals stimulate to help pee?
The ACH.
Almost. Botanicals stimulates the detrusor muscle by mimicking acetylcholine, but not ACH itself. Last question, 4. What type of drug is imipramine for incontinence?
I don't remember, brother. Please tell me.
No worries. Imipramine is a tricyclic antidepressant.
Ah, yeah. Okay, guys, thank you for watching. Peace.